Okay, thank you. Good afternoon, and thank you for coming. And obviously, we're a little bit late, so I'll try and whiz through as fast as I can, speed it up. Um, so, I'm going to talk about prevention. I am not an immunologist at all. I'm a clinician, clinical researcher, and I'm approaching this as a clinician in a clinic would do if he was meeting some families, children with diabetes, and asking the question about prevention. So immunotherapy or biological therapy is the treatment of a disease by activating or suppressing the immune system. Now, this is my simplistic view of what the immunology of diabetes is about. There's beta cell stress. We don't know what that actually means. It could be anything. We don't know what causes it. It could be anything. It could be metabolic demand. It could be nutrients. It could be chemicals. It could be viral. We don't know. But what happens is it alters the endoplasmic reticulum and oxidative distress in the beta cells. That then sets this whole chain reaction off with chemokine release, insulinitis, islet cell damage, and it goes round and round. In some people, most of the children that we meet who present with type 1 diabetes, this is a very rapid process. In many people who get diabetes in later life, it's a very slow process. So it's a difficult area to unravel and take and sort out. So ultimately, though, leading to beta cell loss. Now, this has been shown a few times in the conference so far, the schematic development of the stages of type 1 diabetes. And today, I'm not going to talk about stage 3, which is the clinical diabetes presentation. So I'm interested in the concept of pre-stage 1, stage 1 where you have the antibodies from that process coming out and being present, but you have normal blood glucose levels. Moving on to the presence of antibodies with abnormal blood glucose levels, dysglycemia. And then that ultimately, but not always, but ultimately will lead to the clinical presentation. And that's one of the problems about this whole thing. That process is extremely variable. Sometimes it's a matter possibly of months, sometimes it's a matter of probably decades. And certainly as involvement in certain studies like the Oxford study, the average time of the initial presentation of antibodies was if in years rather than in months. So this is an odd process which we've got to cope with. So what are the potential benefits of screening for type 1 diabetes? So what's been suggested is you get improved treatment effectiveness when you do have to start treatment. You get reduced long-term complications, you get better glucose regulation, pre-symptomatic treatment, benefits for children and young people, emerging benefits for the adults who go on to get the diabetes at long time, prevention of severe imbalances, time for preparation and education, delaying progression, research participation. The important word on that slide is potential. We don't know. This is all guesswork. We have no idea about this, and that's something that we've got to consider, because the people who are really pushing for all of this will see this as a given. The people who are resistant for this will see this as not something that's a given. So we have to be very critical about this and watch what happens as we evolve over the next few years. Will it make life better for people with diabetes? I hope so, but I don't know. So when we talk about screening, there's various aspects for that. There's a screening for the genetic risk, which I'll come back to in a minute. There's the family risk, and and we know about that in terms of associations within parents, first degree relatives, and so on of the children with diabetes. And then there's the risk to the patients. So that screening, which I'll talk about in a second in terms of how we do, has to be accurate if we're going to predict this. All right. And as a pediatrician, I'm used to screening processes, particularly the neonatal heel prick system where you're talking about accuracies of over 90%. So the sensitivity and specificity of the screening in my world has always been extremely high. And we've got to have that for all sorts of screening, I believe, and it's not got to be less from that. We've got to look at side effects of screening. I'm not actually sure there's any physical side effects, but there's certainly quite a lot of potential psychological side effects for the screening. There's all sorts of social aspects and insurance and all this sort of stuff. And then there's the big word, which is the cost. A screening program in a national arena, in a regional center, etc., has a significant cost to it. And then you've got to think about, if you're going to start preventive therapy, whatever that might be, what's the long-term effect of that? So the measures used in screening programs, they're the antibody measurements, which there's several antibodies, but they've been well refined. And in fact, over the last 10, 15 years, or even longer actually, from people like Michael Knip's study in Finland and other groups across the world, that the precision of and the information that you can get from testing somebody and they've got a certain level of antibodies will direct you to the risk that they've got of diabetes. We know that most people that you screen will not have diabetes. Most people who come up positive to the test, which is probably under 10%, many of them will not go on to develop diabetes just from the antibody test. Obviously, you can add into that a glucose measurement to see if they have dysglycemia, and whether you do that with absolute blood glucose levels or response to a glucose tolerance test or C-peptide levels is got to be worked out. And then you can finally add into that now, I think, more emerging, the genetic screening, and certainly from groups such as Andrew Hattersley's group in Exeter, which I know about, they've got some more precise data. So you can create a package of screening now, which gives you a reasonable degree of accuracy as to what the risk for that person is of going on to get type 1 diabetes. But when you're looking at clinical prevention trials, you're going to have to extract those people from the general population. Most of the studies, virtually not all of them actually, not quite, but have been done on high-risk patients. So these are, high-risk people. They are siblings or parents of an identified case. And therefore, the risk in those is higher. It's not as high as you might think, but it's higher than the general population. So if you're going to do screening for the general population, you're looking at technically quite a difficult area. You've then got to extract out those. Are they C-peptide positive or C negative? And the whole point about this is that there is enormous high inter-individual variation. And so determining A, the risk, and B, the impact of a treatment on that risk is going to be quite difficult, and will take several years before we actually come up with idealized solutions. So what can you do? There's all sorts of immunotherapy that you can think about, and basically, I think most of them, well, not all of them, but a lot of them have been tried, and there are a lot more in the pipeline at the moment, attacking all aspects of that immunological attack, which I talked about on the B cell. And there have been one or two trials suggesting on possible factors which might instigate the cause of the diabetes at the beginning. And so these are the sorts of studies which have been done over the last few years. You've got the whole initial program, which was done several years ago now, of the oral insulin tolerization, where you basically gave people in various forms insulin to see if that altered the actual progress of the damage to the beta cells. And subsequent to that have been all sorts of biologicals, and there's a whole list of them here. And this has now been taken up very energetically by many of the national and international trial organizations. And you have to congratulate Breakthrough, originally JDRF, for supporting this considerably. And you've got groups across Europe, such as Inodia, and we've got groups in the UK, etc., looking at the ones that have been suggested here, looking at other ones that have been suggested, and also moving towards potential combination therapy with the biologics and looking at beta cell preservation. There's only one out of these at the moment which has shown positive results, which is teplemzimab, and that's actually been given FDA approval, and certainly it's becoming probably likely that other centers around the world will get approval to use this in pre-diabetes, stage 1 and stage 2 diabetes. Remember, I'm not talking about stage 3 diabetes. However, the data which has been published so far does not go out beyond 2 years. We're waiting for the 5-year data, and it's based on the preservation of C-peptide. It looks very promising and it looks hopeful, but we're not quite sure yet. And as somebody who's been in diabetes for a while, I am always reticent to base my judgment just on one trial, but we'll have to wait and see. The other aspect to it is incredibly expensive. And we're not quite sure how it will pan out at the moment. Certainly in the UK, the rights for teplemzimab have been taken over by one of the major manufacturers, and we'll see how they take to spinning this out in the next year or so. One country, and I have to admit that I'm not fully up to date with their program, but one country, Italy, has decided through a legal framework to actually adopt screening for type 1 diabetes. And this focuses on the antibodies. It's between 1 and 17. It's a national implementation program, and the view is that the early detection will be possible. Again, this is very, very early days, and we'll have to wait and see how this spins out. 1 or 2 other countries are contemplating it, but again, we're not quite sure where we're going. Finally, there's a completely different area of immunological approach, which is the whole business of cell and gene therapies for type 1 diabetes. And these are the sorts of studies which are in the pipeline at the present time. And again, people will be looking at those with interest. But again, these will be incredibly expensive and difficult to set up. So in summary, the pitfalls and the positive natures of prevention. Of course, we would want to prevent it. You cannot not want to prevent diabetes, but we've got to be careful that we're doing something appropriate in terms of a practice of medicine, and that ultimately we're going to do something which will benefit patients. There's been a tremendous checkered history of the phase 3 trials, and nobody's actually gone on to do any stage 4 studies yet. And there's been lots of high-profile failures. We've got to question the predictive value that animal models do in the preparation for these phase 2 studies leading on to the phase 3. The trend, however, is to look for combination therapy with various agents, and that may well be a beneficial area to go. And looking at the adjuncts of biological agents with beta cell preservation. Immunotherapy may be most effective in pre-stage 1 and stage 1. Safety has got to be a concern. The establishment of a national screening program is an issue. It's difficult. It's costly. It is a problem there. And will it actually identify the at-risk population? So I leave you with a lot of questions about this, and I'd be interested later on to see in the discussion if people are taken with this as something that a country like India would take on for type 1 diabetes. Thank you.